Evelyn, you're live, so you can start.
Okay. Good evening, everyone. My name is Evelyn Mwalo, a nutritionist in Bondo County Referral Hospital, and today I'll be taking you through protein energy malnutrition in renal disease. Before we continue, I would like to appreciate that today is our World Kidney Day. This is a campaign that aims to raise awareness globally for the importance of kidney health uh, in our lives. So I think today's theme was just the same as last year's theme, kidney health for all. So it's good for us, healthcare workers, and any other person outside there to always check how your kidney works. This can be done maybe or through normal routines, checkups. Just checking your BP is enough. You can also go check your UECs, and if you see any slight derangement, you can take action. Uh, that said, we'll start our presentation by defining what protein energy malnutrition is. We will also look at the prevalence of protein energy malnutrition globally and even in Africa, if the data is there. We will also like to look at the factors that are contributing to protein energy malnutrition. We will do the we'll look at the nutrition assessment, nutrition therapy, and maybe recommendations and way forward. First of all, what is protein energy malnutrition? Protein energy malnutrition, as defined by International Society of Renal Nutrition and Metabolism, is a state of decreased body stores of protein and energy fuels. So this deterioration of the clinical nutrition status is always characterized by low visceral proteins like the serum albumin, we have prealbumin, also cholesterol, and even the decreased anthropometric measures. When we go to the prevalence, obviously there's a high prevalence of protein energy malnutrition both in non-dialyzed patients with advanced kidney uh, disease and also those that are receiving dialysis therapy. We have two types of dialysis therapy, that is the hemodialysis and the peritoneal dialysis. So approximately one third of maintenance dialysis patients have mild to moderate protein energy wasting, and then 6 to 8% of these individuals have severe malnutrition. So these statistics are of major concern, and because of the markers of protein energy malnutrition are always strong predictors of morbidity and mortality. Globally, a study that was also done with the same International Society of Renal Nutrition and Metabolism, in the studies that they did, they found out that in CKD stage 5 to 3 to 5, protein energy malnutrition prevalence was ranging between 11 to 54%. That's a very big gap. Let's now look at the contributing factors to protein energy malnutrition. There are several factors that contribute to protein energy malnutrition, and one of them is decreased nutrient intake relative to what the patient needs. And this normally is caused by anorexia, which may be endangered by the uremic toxicity. Another cause, maybe decreased nutrient intake, can be emotional depression. Most of these patients, they can be depressed, and if not seen early enough, can cause protein energy malnutrition. We also have medications. There are different types of medications that these patients take, and may interfere with the nutrient intake of these patients. Then we also have inflammatory disorders that can cause decreased nutrient intake. Another factor is socioeconomic constraints. These patients, some of them are from poor backgrounds, like the poverty, let me just say poverty. So they have inadequate finances to purchase and even prepare their foods. And then the physical incapacity to prepare the foods. Maybe they are bedridden, they can't prepare the food enough, and social background is also not good. And then we have losses of these nutrients during dialysis. As I said earlier, we have different types of dialysis. We have peritoneal dialysis, and we also have hemodialysis. So some of these patients, when they are put in these treatments, the treatment itself is catabolic. So they may lose some proteins in them, like in HD, they are capable of losing 2 to 8 grams amino acids per session. So you can see every session someone losing 6 to 8 grams of amino acids. And then for those receiving peritoneal dialysis, they may lose 8 to 12 grams of proteins per day. So, if not taken good care of, they may develop protein energy malnutrition. We also have losses through blood, gastrointestinal loss, like 100 milliliters of blood. A patient is able to lose 14 to 17 grams of protein. I hope we are going on well. In case of any question, we'll just note down, or and then we discuss at the end of the session. Another factor that may contribute to the protein energy malnutrition is poor adherence to the prescribed dietary restrictions. Most of the time, we do restrictions, but if the restriction is overzealous, the patient may not adhere to that diet, and this may cause malnutrition. We also have hypercatabolism. This mostly caused by the comorbid illnesses such as cardiovascular diseases. We have diabetic complications, we have infections and sepsis, and many other comorbid conditions. Then we also have catabolic effects of the hormones, especially the PTH, the glucagon, and the cortisol. And then there is that dysfunction of the growth hormone and the insulin growth factor. Another cause of protein energy malnutrition, like the growth factor, the insulin resistance caused by the CKD. So we've seen the factors of protein energy malnutrition. Let's now see the consequences of protein energy malnutrition. One consequence is impaired wound healing. Another one is increased hospitalization. And then we also have susceptibility to infection, poor rehabilitation, malaise, and fatigue, and even increased morbidity and mortality rate, as I said earlier. Some of the complications caused by CKD on the GIT also contribute to protein energy malnutrition. For instance, impaired gastric emptying. We also have impaired intestinal motility, disturbances of digestive and absorptive functions, especially the proteins. And then we also have the alteration of the intestinal bacterial flora. And then the fat absorption may also be delayed. So before you know that a patient is wasted, there are tools that we may use to know that this person is wasted, because some of them we can't see with our own eyes. So normally for the assessment, the nutritional status assessment, there is no single gold standard measurement. Therefore, a panel of measurements recommended. We have one that we use assessment of dietary nutrition intake. We also do anthropometric assessment, including body composition. We can also use laboratory values, and then we also have one called scoring. So if you use these assessment tools, you are able to know that someone is malnourished or at risk of malnutrition. So we'll start with nutritional intake of a patient. We have both direct and semi and indirect assessments. The direct ones, we can use diet recalls, we can use diaries, we can use food frequency questionnaires. For instance, a 24-hour recall will help the patient to remember food intake in the previous day and to quantitate what he takes on a daily basis. We also have a food record. A food record gives us quantitative and qualitative data on food intake collected for an average of maybe 3 days when they're taking that food. Then there's also that food diary, which is very useful, especially if the patient weighs the portion of the food. The last one was a food frequency questionnaire, which is used to assess frequency of food consumption of foods, items, and even groups during a specific reference time period, which may not be the period that the patient actually bases his or her recalls on. So we can use maybe like the direct assessments for the nutritional intake. We can use more than one tool in that category. You can also use even one tool, especially when a patient gets admitted in the hospital. You can choose to use a 24-hour recall to know what the patient ate previously before he or she was admitted in the hospital. Then there is that indirect assessment, normally based on urea nitrogen appearance, called PCR. The PCR is calculated and is always a good index for dietary protein intake. It is expressed in grams per day. Then we have body composition. Body composition can be based on weight measurement, where we have the BMI, we have the height for weight for height, especially for children. We have the edema-free and the fat-free weight. We can also do skin and muscle anthropometry, where we can use the caliper, skin fold, and even muscle mass using the work tapes and so on. Then we also have total body elements. For instance, the potassium. If you see a patient, a CKD patient having low potassium, you should be worried. Then we also have energy beam-based methods. Normally, I doubt if we do it. Maybe very few hospitals do it here in Kenya. That is the DEXA and the BIA. Then lastly, other methods that we have is underwater weighing of the patients. Lastly, we have scoring systems. Scoring systems are one tool that we use for scoring is the SGA, Subjective Global Assessment. So we also have that one that is always modified, the MIS. So the SGA is a simple clinical method of evaluation of nutritional status. So normally it has several things that you assess from the patient, like the history and the symptoms. It will tell you, you'll know the percentage of weight loss in the last 6 months. You'll also know how the dietary nutrient intake of the patient, the presence of anorexia, nausea, vomiting, diarrhea, and then abdominal pain. There's also that part of functional capacity of the patient, which is very important, especially in CKD patients. Then the metabolic demand in the view of activity of the patient. Then we also have the physical parameters to focus on the SGA. Number one is the assessment of the subcutaneous fat. We have also assessment of muscle wasting in the temporal area, the deltoids, and the quadriceps. Then there's also, you'll also check on the presence of edema, especially the sacral and the ankle edema of the patient. And then it also allows you to check on the presence of ascites in that patient. So one major advantage of this SGA tool is that it gives objective data and several manifestations of poor nutritional status of the patient. And so it has a good reproducibility and it correlates well with the outcome of the kidney condition, especially the end stage renal disease. And then we also have limitation for this tool. The limitation here is mostly it relies on clinical judgment and then that ability to tailor specific nutritional therapy for the patient. So another way of knowing or assessing protein energy malnutrition is use of lab values, as I said earlier. So here in lab values, we check on the visceral proteins, the ones I said, albumin, prealbumin, transferrins. We have under lipids, we have cholesterol, triglycerides, and other lipoproteins. We can also check on the creatinine and the serum urea nitrogen. Under that classification, we call them somatic proteins. Then we also have growth factor, the insulin growth factor 1 and even the leptin. So we'll start with the serum albumin. Serum albumin, uh, the the NKF recommends it to be measured monthly for the patients suffering renal condition because low levels is a strong predictor of mortality and hospitalization. So normally if you see an albumin that falls below 4 grams per deciliter, that's a very strong predictor of mortality and even morbidity. We also have serum transferrin, though this is not a good indicator for nutritional status because of the fluctuations in iron stores, especially because of the presence of inflammation and changes in volume status. But it can show us somehow that there is uh, hypercatabolism taking place somewhere. Then another one that we have is prealbumin. Prealbumin plasma concentration provides a consistent assessment of visceral protein and can be used to assess the response to nutritional status of a patient when maybe you've started doing nutritional intervention to that patient. So most of the time, prealbumin is normally excreted and metabolized by the kidney and tends to accumulate in renal failure. So in case you find a patient with a prealbumin level below 30 milligram per deciliter, it's an indicative of malnutrition, especially on a patient of hemodialysis. So you will have to take care of that for the patient to come up. We also have amino acids. Um, there's a variable plasma amino acid pattern in end-stage renal disease. In general, the levels of essential and branch chain amino acids decreases while the non-essential one normally remain normal or even increase. So you should take note of that. Then there is that blood urea nitrogen. Blood urea nitrogen mostly in CKD patient is always high because the kidney is not able to remove them. So when you see that the blood urea nitrogen, there's a gradual reduction of blood urea nitrogen, that means the patient is becoming wasted. It reflects the balance between urinary generation and the removal. Low pre-dialysis blood urea nitrogen levels has been associated with increased mortality. Uh, so most of the patients that are undergoing dialysis, most of them are very much monitored. The catabolic rate are monitored, sorry. Then we have creatinine. Creatinine normally is produced from non-enzymatic creatinine metabolism in skeletal muscles. So, estimating the rate of creatinine production has also been used to assess lean body mass of these patients, especially the stable patients, to know. Sorry, there's a blackout, and I'm hoping my presentation. I'm so sorry for that. I got lost because of power. My desktop is power dependent. So I'm so sorry. We will continue with from where we left. Uh, I wanted to talk about the criteria for clinical diagnosis of protein energy malnutrition, the one that has been recommended by International Society of Nephrology. They say that serum chemistry, if the serum chemistry of albumin falls below 3.8 grams, then also serum albumin of less than 30 milligram per deciliters, and then serum cholesterol less than 100 mils per deciliter. We also have a body mass of these patients when the BMI is less than 23 uh, kg per meter square. That's a very strong indication that maybe protein energy malnutrition may set in. So, and then there's also an intentional weight loss of over 5% over 3 months or 10% over 6 months. Then the total body fat percentage less than 10%. Another criteria for clinical diagnosis is muscle mass, where muscle wasting uh, of 5% over 3 months and that of 10% over 6 months. Then dietary intake of the patient. If the patient is unintentionally not able to finish their food, especially the DPI of less than 0.8 grams per kg body weight per day for at least 2 months at least 2 months, that is for dialysis patients, and also less than 0.6 grams per kg body weight for patients with CKD stage 2 to 5. That's a very strong indicator of protein energy malnutrition. We also have low serum albumin, the one I said before, less than 30 milligram per DL. We also have low blood urea and creatinine levels for patients, mostly for patients with residual kidney function. Then the transferrin level of less than 150 milligrams per deciliter. And when the insulin growth factor concentration is also less than 300 microgram per liter. Another strong Another strong clinical diagnosis for protein energy malnutrition, I said earlier, was low pre-dialysis serum potassium and even phosphorus concentration. Then there's that continuous decline in dry weight, especially for patients undergoing hemodialysis. If you have a patient that most of the time, if they come for dialysis, their dry weight keeps on dropping and dropping and dropping, you should really take good care of you take keen interest on that and maybe start giving supplementation or any other intervention that will not make them have protein energy wasting. Another diagnostic criteria is body weight of less than 80% of ideal body weight of that patient. So we have different strategies of preventing or and also treating protein energy malnutrition. Some of the strategies that we have is one, early initiation and adequate doses of renal replacement therapy. If you have a patient that has entered a stage that needs dialysis, kindly do early referral of that patient to dialysis. Very crucial. Another thing that we should really get good care of is optimal dose of dialysis. When a patient is undergoing dialysis, be it peritoneal dialysis, be it hemodialysis, make sure that they get optimal dose of dialysis. For hemodialysis, normally the urea reduction ratio should be more than 70%. And then we also have use of biocompatibility HD membrane so that they get good clearance. And then another strategy that we always should do to prevent or treat PEM is rapid treatment of or reversing the inflammatory processes. Inflammation, when someone has inflammation, obviously they'll have low appetite, leading to reduced intake of nutrients. And another thing that we should really take good care of is ensuring that we have adequate nutrient intake and also prevention of the acidemia that is brought about by metabolic acidosis. How do we enhance nutrient intake of a patient with renal disease? Number one, we have dietary counseling. We support and optimize on the nutrition part. Another thing that we should majorly do when we are dealing with this patient is we should not overdo dietary restrictions. Let's avoid diet restrictions, especially with patients with poor intake. A patient who is not taking good enough nutrients that is prescribed, do not do more restrictions. We will be doing more harm than good to this patient. Another thing that we can do to ensure adequate nutrient intake is by offering oral supplements and even snacks. When the patient is also uh, not taking enough nutrients, we can do tube feeding if medically appropriate. And then for those going for hemodialysis, there is that thing called intradialytic parenteral infusion. We can also do that for the patients. And then for patients with undergoing peritoneal dialysis, we can advise them on using the amino acid dialysate for those PD patients so that they get the amino acids in the dialysates. We also recommend treatment of gastroparesis and any other gastrointestinal condition that may make them have malabsorption of nutrients. Make sure that you also achieve glycemic control of this patient so that we don't have insulin resistance, so on and so forth. Another way of ensuring that they take adequate nutrients is by correcting their electrolyte abnormalities. If the patient have hyperkalemia, make sure it is corrected. When the patient has hypophosphatemia, so and so on, make sure you correct the electrolyte abnormalities. When they are also low in certain vitamins, make sure you supplement them. But remember, CKD patients do not just take any multivitamin. We have water soluble vitamins, we have the fat soluble vitamins. Fat soluble vitamins is not recommended for these patients because they may have toxicity. So we always recommend uh, supplements that only have water soluble. An example is a Replavit for renal patients. So make sure that they are supplemented with the B complex and even the vitamin C. Another thing that we should check on this patient is we evaluate them for and address the depression. A depressed patient will not eat well. And if they don't eat well, the end result is protein energy malnutrition. Other interventions we have is exercise. As much as they are frail or weak, we have to make them have some mild exercise. We should also involve social work because I said earlier we have factors contributing to that. For instance, the socio-economic part of it. If we involve the social worker, we are able to deal with that aspect easily. There's also that pharmacy support. These patients, most of them are given a lot of medicine. Someone has diabetes, he has hypertension, other chronic illnesses at the same time undergoing dialysis. So we need to support them. We involve the pharmacy. Actually, this should be a teamwork from all aspects: the pharmacy, the clinical part, the nutrition part, social worker, counselor, everyone, so that we make sure that they adhere to the regime that they have been put on. And then finally, transplantation, especially on end stage renal disease. Most of the time, these patients, the only treatment that now will now make them better is transplantation. As much as we tell them to do hemodialysis, peritoneal dialysis, also try talking to them on the aspect of transplantation so that their well-being can be taken care of. That said, we now want to do nutrition therapy for these patients, and we want to know how well we can treat them using nutrition therapy so that their life can be well. For us to do nutrition therapy, we need to do individualization treatment. This one was said in yesterday's presentation and the other day's presentation. Individualized treatment is the best way to go when doing nutrition therapy. First of all, the adherence to the renal diet is always very difficult and stressful. Remember someone telling you to take low sodium diet, etc. and etc. So it becomes so stressful at times and very difficult. So if you prescribe a diet, make sure you individualize it so that you help the patient in terms of the cost of the diet. You'll also help the patient in terms of palatability and also maybe the comorbidities that the patient has. Another important aspect that we should always check is the cultural eating habits of these patients. You can't impose someone to eat something that is not culturally accepted in their culture. So make sure you take these things into consideration and also make sure that you reinforce all members of of the family and even the medical team. You reinforce their work when it comes to this prescription. Another thing that is also very important when you are doing nutrition therapy is the compliance. You should be able to assess the compliance of this patient adherence, especially uh, you can do it monthly or maybe on regular basis as they come to their treatment. Or you can even do a home visit if that allows. Do a home visit and check whether they are complying with the dietary regime. Um, we have protein and calorie requirements and recommendations that should be based on the peer body weight for healthy subjects of the same age, same sex, height, and even body frame. So the recommendation that you give these patients, I think they vary. We have those that we give for patients who are not yet on dialysis. There's that recommendation that you give to the patient that are already on maintenance dialysis. They vary. There's that one called conservative management, and then there's that one that we just do for patients on dialysis. For conservative management, because the kidney is sick, is not able to balance electrolytes, is not able to remove fluids, is not able to remove the toxins that comes as a result of foods that we eat. The conservative dietary management is always low in protein, but when they start treatment of hemodialysis, the protein intake is always increased. As I said earlier, there is that catabolic process that the dialysis machine does to the protein. So most of the time, their protein intake is always increased when they start doing dialysis sessions. We'll see the protein intake in non-dialysis and also the protein intake in hemodialysis. We'll also see energy intake and then for the non-dialysis patients and also for hemodialysis patients. Most of these things that I'm saying right now, they were said yesterday, especially when you were tackling hemodialysis. Um, for a patient who is not on dialysis, protein intake should always be between 0.6 grams to 0.8 grams, unless the patient is ill. That is when we can move it to 1 gram protein per kg per day. When the patient is on dialysis, we increase the protein intake from 1 to 1.2 grams per kg per day. And when they're on peritoneal dialysis, it's even increased further up to even 1.5 grams per kg per day. For energy intake, the recommended allowance for non-dialysis CKD patients, we have 30 to 35 kilocalorie per kg per day. I think it's more or less the same in dialysis patients, still the same as 30 to 35 kilocalorie per kg per day. Unless the patient is wasted, we can increase it to more than 35 kilocalorie per day. For sodium intake, as it was said yesterday, it's less than 2 grams or to even 2.4 grams per day. This cuts across both for non-dialysis patients and for the dialysis patients. For potassium, we reduce the amount to less than 2,000 milligrams per day for both uh, non-dialysis patients, non-dialysis CKD patients, and also dialysis CKD patients. Then phosphorus levels, we can do 800 to 100 milligrams, both for non-dialysis and also dialysis patients. Vitamins, I already said earlier that it's recommended for CKD patients to be supplemented with vitamins. Then we also have fluid monitoring for these patients. When one followed yesterday's presentation, we talked of intradialytic weight gain, mostly happening with those patients that do not adhere to the fluid requirements. So when a CKD patient comes to your facility, when you're dealing with them, make sure you really monitor their fluid intake and output. You can do a 24-hour urine output, then you give an allowance of maybe 500 mils. And for the patients that are edematous, you can do 24-hour urine output, and then you give an allowance of 300 mils per day. It's always recommended that you train them and show them that whatever they take inside will not come out all, because the kidney is impaired and they cannot remove the fluids through urine. And in this matter, when I talk of fluids, I mean anything liquid at room temperature. I don't only talk of water. We can talk of tea, we can talk of soup, we can talk of milk, the juices, the porridge, anything liquid at room temperature. Those are the fluids. So when you are dealing with this, let's say a patient had 500 mils urine output in 24 hours. You will add another 500 allowance, giving us a total of 1 liter. So this 1 liter doesn't necessarily mean only water. It means anything that the patient will be taking from morning to the next 24 hours. If the patient is going to take medicine, make sure that they take medicine with the little water that will not make them have fluid overload. I hope I'm clear enough and everyone is following. Uh, all that said, we normally recommend or have recommendations based on whatever we see or whatever we manage in our facilities. So, me as a nutritionist, my recommendations for those seeing patients in their various facilities, those dealing with CKD patients, first of all, we should able to understand and apply nutrition principles so that we don't uh, wait until these patients develop protein energy malnutrition. So, number one recommendation that I have is periodic assessment of nutritional status. Every time that the patient come to the hospital, make sure you weigh them. We have the weight taken before dialysis and weight taken after dialysis. The weight taken before dialysis is called weight because they still have that fluid overload in them. And then weight taken after dialysis, we call it dry weight. So make sure you monitor this weight. The weight that you take mostly before dialysis, is it almost on the same range? Normally, they add some little weight because of the fluid overload. But if they add excess, you start questioning yourself, is the patient adhering to the fluid intake? And also a dry weight. If your patient comes to the facility and every time you take dry weight, the dry weight keeps going low, that should be a good indicator and enough indicator for you to start uh, doing supplementation or treatment of protein energy malnutrition for this, because if you don't do that, eventually the patient will die. So there is that periodic assessment of nutritional status, which should be redone in routine care and also permit early recognition. Another thing that we should do, providing an institution of appropriate therapy for the best improvement of nutritional status. Appropriate therapy here, when I talk of it, means if you do the recommendations that we gave earlier, like patient on dialysis giving 1.2 grams protein, that is appropriate therapy. If you see a patient that is starting to lose some BMI, make sure you do appropriate therapy by either supplementing them, putting them on NG tube feeding. Also, can also do intradialytic protein uh, parenteral nutrition. Sorry. Then another recommendation that I have, or we can do in our facilities or when in our management of CKD patient, we should involve renal nutritionists or even a dietitian as a member of the medical team. If you don't involve these people because they are well trained enough in the management of nutrition in these patients, you may miss some aspects in their management. So make sure you involve the nutritionist and the dietitian in the management, because they'll always calculate the dietary requirement of this patient. They'll monitor the patient's energy intakes, so on and so forth. Um, as I wind up, I'll say that protein energy malnutrition is underappreciated. Although it's largely preventable and completely curable, we should, uh, as healthcare workers, monitor our patients so that we avoid protein energy malnutrition. And my slogan is, do not starve your patients. Do not starve your patients with unnecessary restrictions. And when you are doing restrictions, always check the lab values of these patients. Don't just do a blanket restriction. If the patient is low in protein, by just checking the serum albumin, the prealbumin, you are able to know that this patient is wasted and I should not restrict protein. If the patient is low in potassium, and up there we can, we said earlier that the kidney condition may make electrolyte imbalance. So if maybe the kidney makes the hyperkalemia and you always just think that it's hyperkalemia all the time, one time the patient will come with hypokalemia. And with your diet that is always written that low potassium diet, you may end up killing this patient. So always work with the lab results so that when you are doing your therapy, you tailor your treatment based on the lab results, based on the body compositions, based on the weight or BMI of the patient. Thank you for listening, and I now welcome any question based on the presentation or any other thing, and then the fellow panelists to join me. Thank you. Any question from the panelists or additions?
Hello.
Priscilla, do you have any addition?
Thank you, Evelyn, for that wonderful presentation. I don't think I can emphasize more on PEM. I think you've done it well. Thank you so much.
Hello.
Sorry, I can't
Hello.
hear you.
And now, can you hear me, Evelyn? Can you hear me?
Sorry?
Can you hear me?
Penina?
Priscilla, can you hear me? Can you hear me now?
Yes, I can now hear you.
Well, thank you, Evelyn. The presentation was perfect. But you want you to clarify. Somewhere you say that do not restrict if the patient has poor appetite. Kindly expound.
Okay, I said do not restrict if the patient is not taking the recommended dietary allowance that you had given the patient. Let's say, for instance, you had done restrictions on protein intake, but now the amount that you gave the patient still, he or she is not able to finish this up. Obviously, the patient will start being wasted. The patient will start being wasted. So to avoid this, you go slow on the restrictions so that you don't the patient don't develop the protein energy malnutrition. But most importantly,
Oh,
always go with the lab values. Lab values very important.
okay.
Sure, and even to add on that, it is advisable that we at least do our screening every other quarter. Like we do screening quarterly for our dialysis patients so that it is easy for us to monitor when malnutrition is setting in. So I think maybe if we adopt tools like SGA and we do the screening quarterly, sorry, it will be helpful for us to, you know, catch the PEM before it gets to severe malnutrition and at the end of the day we lose our patients. So I think it's important.
Yeah, thank you. Effie, would you like to add on that?
There is a question being asked.
Yes.
Uh, there is a question being asked about yesterday discussion by Effie
Mm-hmm.
about the heating of food in the microwaves. And I think these go hand in hand with the heating of the food in the pressure cookers. What this does, it's because of the high heat, it destroys the food nutrient, so leading to the loss of most of the nutrients. And as you know, in the kidney disease, we do a lot of reaching. At times, we do boiling. So, if you continue using the microwave and the pressure cookers, more nutrients will be lost.
Someone is saying that dietary restrictions, especially for patients with multiple diagnoses of kidney disease with either diabetes or hypertension, could also contribute to protein energy malnutrition due to limited diet diversity. So we could go an extra mile to increase diet diversity and adequate caloric intake for such patients. Thank you, Salome, for that addition. That's a very important point there to avoid protein energy malnutrition.
Someone is Gadoni Kahocho. She is asking a question. Please talk about interdiaretic parenteral nutrition in renal patients with PEM who are unable to get their nutrition through the enteral route.
Um, I think Effie in? Effie talked about it yesterday in hemodialysis patients that are not able to meet the nutritional requirement. Normally, for these patients, when they are undergoing dialysis, the parenteral nutrition also is considered in that fact. It's factored in so that at least they get nutrients in their body. So some facilities do that, and I'm sure Priscilla, your facility does it. In my end, we've never encountered such a scenario, of which one day I think I'm hoping that we'll able to do.
Unless there is any other question, I think I don't see any other question on the comment chat. There is another question. I think is this the same Gadoni? Is that comment on use of pressure cooker and loss of nutrients have any scientific backing? Please share papers on the same. Gadoni, I think we'll do more research on that. And by the end of the presentation, still have more presentation to come, we'll consider answering that question to at least provide any proof if there is any on Google or any form.
That question for Gadoni will be answered in the coming presentations, because we still have more presentations to take. We'll be able to know, or actually, scientific evidences matters a lot when we are dealing with these patients. So, in the coming presentations, we still have more to come, and even under nutritional management of these patients, we'll be able to know the type of preparation that they should be doing for their foods, how we should be able to leach or do blanching for their food, so that the nutrients that we don't need come out, and even the nutrients that we need stay in. Any more question? Naima, do you have any addition to make?
And for now, I don't really have any addition. What I can say is the presentation is good and they articulated their presentation well. I think you touched on all the points. Thank you.
Thank you. Damaris? Thank you, John Deretu, a dietitian from Botswana. Thank you so much for that. Please, you feel welcome. We still have more presentations to make in the coming week. Damaris, do you have anything to say? I think we've lost her. We still have some 5 more minutes to go. 5 minutes to go. If you have any addition to give here, it's highly welcome. So, if you don't have anything, my parting shot is let's take good care of our patients. Let's always monitor our patients and make friends with our patients. They are able to tell us what uh, they feel, how they feel, what they can take, what they cannot take. Let's just be close with our patients. So most of the time, as our academy has pointed out, that protein energy malnutrition is usually missed out by most nutritionists. So let's have a tool. We should be having tools that we use in our patients, in our setup, to monitor these patients. For example, the SGA tool, we have the IMS tool, MIS tool. We also have the anthropometric measurements, just the usual ones. You are able to point out that this your patient is not doing well. We should also be able, under lower stress of this, to check on the laboratory results. Do not just look at the patient physically and conclude that this patient is not malnourished. Do other assessments. The assessments we were told by Priscilla in previous presentation, we should check on the anthropometric, we should check on the clinical, we should check on the laboratory, and finally we should score these our patients using the SGA tool. And with all that mentioned, we are able to take good care of our patients and avoid protein energy malnutrition in these patients. Thank you for listening. Uh, Thank you for your time. The person who was presenting today is Evelyn Mwelo, a nutritionist and a student of Renal Nutrition at NDA. Thank you all.